Buenos dias. My name is Kathy Smith and I'm a psychiatrist from Sydney, New South Wales, Australia. I work at Concord Hospital in the Sydney Local Health District. And I'm here to present today on behalf of the team that I work with at the Collaborative Centre for Cardiometabolic Health and Psychosis. Oops, I've gone a little bit too far. Our unique service-structured model of care has been designed to overcome some of the barriers that persons with severe and enduring mental illness face in negotiating traditional healthcare structures in the Australian setting. The purpose of the innovation is to reduce the preventable premature mortality relating to cardiometabolic disorders in this group. For those members of the audience who do not have a background in mental health, I'm going to take a moment to put into context the need for this innovation. Two Australian reports, the Duty to Care in 2001 and the Australian National Report on Mental Health and Suicide Prevention in 2017, both showed that people with severe mental illness are likely to die earlier than those without mental illness, and that those deaths are often due to preventable physical health disorders. For example, people with severe mental illness are 6 times more likely to die from cardiovascular disease. That there was no improvement in the 16 years between these two reports illustrates the failure of traditional Australian health service models to address this issue. It is important to note, however, that this is not just an Australian issue. The global tragedy of excess mortality among people with serious mental illness transcends geography, different systems of healthcare, and different approaches to healthcare financing. According to the European Union, the prevalence estimate of lifetime mental health disorders in Spain is 19.9%. So Spain then, like Australia, faces the prospect of significant physical health morbidity and mortality among those with mental illness. And sadly, most of this preventable premature mortality is preventable, and the gap is widening. So in the 2005 Australian census, that was proven. So this is the current trajectory of life expectancy. And this is the trajectory of life expectancy with those with severe mental illness. Hopefully in the next census we'll find some improvement. The Australian Health Commission has called this an injustice that runs contrary to the United Nations principles for the protection of persons with mental illness, and subsequently asked the question, what model of care would provide comprehensive, effective, integrated physical health care to people with severe and enduring mental illness? So arising out of this need, I'm a little bit quick there, arising out of this need to do something to change the health of consumers with severe mental illness, the Collaborative Centre for Cardiometabolic Health and Psychosis has evolved. It has been a work in progress for more than a decade, but in 2014 it was established in its current form as an outpatient service by 3 doctors a little bit ahead of the curve. Professor Tim Lambert, Professor of Psychiatry at the University of Sydney, Concord School, Associate Professor Roger Chen, an endocrinologist, then also of Sydney University and Concord Hospital, and Dr Jeff Snars, a psychiatrist at Concord Hospital in the Sydney Local Health District. And we refer to them affectionately as the 3, the picture hasn't come up, sorry, the 3 founding amigos of CC-CHIP. So, what is CC-CHIP? We're not a food, even though we sound like one. The Collaborative Centre for Cardiometabolic Health and Psychosis is a multidisciplinary, integrated, consultative service that aims to assist healthcare providers to effectively screen, detect, acutely manage and monitor a broad range of cardiometabolic risk factors among adult consumers with severe mental illness. CC-CHIP provides an opportunity for consumers with mental illness to see multiple specialists and clinicians in one afternoon that would usually take months, if not years, in the Australian sector to see. The clinic places consumers at the core of its business and integrates with a wide range of services and stakeholders to deliver the best possible service through evidence-based practice. By combining this innovation in service delivery with patient-friendly visual feedback and digital risk calculation, Sistership aims to reduce this premature preventable deaths. So in the Australian context, the primary medical healthcare provider is the general practitioner or GP. To effectively manage cardiometabolic risk, though, in those with severe mental illness, in addition to the GP, the consumer might need to see a psychiatrist, cardiologist, endocrinologist, dietitian, exercise physiologist, nurse and/or dentist. So the traditional and current Australian outpatient healthcare model would involve the consumer and/or the GP identifying the cardiometabolic risk. The GP would then need to refer the consumer to up to the 7 clinicians. The consumer would need to negotiate booking those 7 appointments within either the private or public health sector, travel to each appointment, pay any out-of-pocket expenses relating to these appointments, not all of which are covered by our universal healthcare system. It is likely to take some time to see all practitioners, perhaps even years, as waiting times in the public sector for health issues that are not considered urgent can be in the order of months. You can see there as our little man makes his way from specialist to specialist, his number of referrals in his left hand is decreasing, but so is the amount of money in his right hand. So if the consumer has persisted, they then need to implement any of the recommendations made. As you can see, to complete this round of consultations would require motivation, organisation, the ability to persist, financial resources, and the cognitive ability to recall, process and use the mostly verbal information given to you by the respective practitioners. Some, if not all of these requirements would be difficult for those with serious mental illness. Further, the lack of integration between healthcare providers results in consumers feeling confused by conflicting advice, or it may require the consumer to take carriage of the communication between healthcare providers. This is a challenge for any consumer, but especially so for those with serious mental illness who often lack the confidence or agency to ask questions. So what then is different about Sistership? The Sistership model of care inverts the traditional service model by gathering all 7 practitioners together in one clinic and bringing the consumer to that clinic. This creates a one-stop shop which places the consumer at the centre of the clinic experience. Prior to the clinic, information is gathered, including a referral from primary care provider, medical and other history, pathology results and a medication summary. This ensures that the consumer does not need multiple visits for the assessment and that the team can also spend more of the clinic time on intervention. Lost my slide. Okay, so then the pathology collected to assist in the assessment of cardiometabolic risks includes, among other things, fasting glucose and lipids, HbA1c, apolipoprotein B, and high-sensitivity C-reactive protein. So then as the consumer moves through the clinic, they start to develop an understanding of the state of their cardiometabolic health and to accumulate a written plan regarding actions to change their health. The consumer does not pay for the service, as we use a combination of existing funding models within the Australian healthcare system, combined with financial support from the Sydney Local Health District under a program entitled Living Well, Living Longer. All team members are experienced in working with consumers with mental illness and as such are able to tailor their intervention to the consumer's needs, capacity and supports. This means that any goals and plans that are made are sensible, achievable, affordable, of meaning to the consumer and build on that individual's strengths. At the completion of the clinic, the practitioners meet for a multidisciplinary case conference. Each consumer's history, pathology and calculated risks are reviewed. The team is then able to consolidate the evidence-based but highly personalised set of recommendations for each consumer. The consumer's cardiometabolic risk and the recommendations to address this risk are conveyed to the consumer's primary care provider, the GP, and to the mental health team in a comprehensive letter. The Sydney Local Health District Mental Health Service has developed with local general practitioners the Mental Health Shared Care Agreement. The purpose of this is to derive a shared understanding between the Mental Health Service and the GP about who will take responsibility for which aspects of a consumer's physical health care. Mental health care coordinators support the consumer's attendance at the Sistership clinic with a visit to the GP after the clinic in order to follow up the recommendations captured in the letter. This completes the integration of care. And you can see where the arrows are that Sistership is an integral part of the Mental Health Shared Care Agreement. So I think many of you would be familiar with working with multidisciplinary teams, but the functioning of our team is enhanced through the use of integrated and complex information technology innovations that have multiple benefits to the consumer. So I've expanded now our Sistership team to include our information systems. So the Sistership database is a multi-purpose instrument that captures, stores, processes, uses and expresses in real time all the information that each clinician needs to assess and manage the cardiometabolic risk of mental health consumers. During the clinic, each clinician contributes to the live database of information. This improves the accuracy of each individual consumer's cardiometabolic risk assessment. And this is important because the more specific that any risk assessment is, the more useful it can be for guiding treatment decisions. The AHA and ASCVD risk algorithms automatically calculate and are available to each clinician. As knowledge accumulates in the database, each subsequent clinician can use this to educate the consumer and plan more personalised interventions. Each clinician can see the other's information and intervention at the time of their own consultation. And this minimises confusing or conflicting feedback. So in general, people with serious mental illness, although they might have significant cognitive problems, have a relative sparing of their visual processing efficiency. So each aspect that relates to the cardiometabolic risk, such as BMI and waist circumference, lipids, glucose and blood pressure, are subject to a colour coding: green for healthy, amber for to be concerned, and red which indicates needs immediate attention. This serves a dual purpose. Non-medical clinicians can appreciate the severity associated with the risk parameter, as can the consumers, with green, amber and red having a universal meaning. The greatest benefit really of this Sistership integrated IT is definitely the ability to educate, engage and motivate the consumer about their health. Consumers with severe mental illness have cognitive problems that impact directly on their capacity to process information. People who are completely disengaged can stop, learn, look and concentrate hard as they start to truly appreciate the state of their health. This lipid dashboard, for example, will pop up live. The black line, which represents the consumer's actual test result, sort of slides into position. And people can start to see quite visually for themselves where their health is at. And it's not uncommon to get the comment when they see their black line in the red in quite a few squares, that's not good, is it? The power of this is really that even consumers who are quite sort of impaired and have quite a long-standing kind of cognitive deficit or blunted affect will actually get engaged by seeing this on the screen. And those that have been engaged can shift further into action. I'm just going to very quickly, before I finish, show you our heart age simulator. So you can see on the right, in the amber is the patient's actual age, and you can see on the left the Framingham calculated heart age. And you can see the quit smoking, reduced lipids and reduced blood pressure. So in real time in the clinic, you would sort of show them that and explain to them that their heart's under considerable sort of strain and is more like the heart of a much older person. And then you would say, hit the quit smoking button. And they would see the dramatic drop in the heart age if they were to quit smoking. And then if you were to hit the reduce lipids button, you see a further drop again. So that's a very powerful way of giving people feedback. I think there's a very emotive connection to the heart, which continues to be understood even if there are severe impairments. So Sistership is an innovation in service delivery that provides comprehensive and integrated physical healthcare to people with severe and enduring mental illness, which uses patient-friendly visual feedback, digital risk calculation, and is integrated with existing information technology infrastructure and other services. There's a website, and Professor Lambert, who's the director of the service, would be very happy for you to contact him by email. And thank you for the opportunity to present our small example of integration in this vast ocean of integration need. Thank you.